Speaker is Andrée-Anne Ledoux, who is a scientist and assistant professor, scientist at URI and assistant professor at the University of Ottawa. She is in her early career as a scientist in the neuroscience department, faculty of medicine, and she's an adjunct professor at the neuroscience department at Carleton University and in the School of Psychology at the University of Ottawa. Today, she's going to bring us up to date in an area on pediatric concussion, bringing objective evidence into play, pediatric concussion assessment of rest and exertion. Please welcome Andrée-Anne.
Hi, everyone. Thank you, Dr. Duffy, for the introduction. Like Dr. Duffy said, the title of my presentation is Bring Objective Evidence into Play, Pediatric Concussion Assessment of Rest and Exertion. Perhaps this should be maybe more trying to bring objective evidence into play, and you'll understand why near the end of our presentation, of my presentation. So my funding and conflict of interest, I'm currently supported by the Innovation Fund of the Alternative Funding Plan for the Academic Health Science Centre of Ontario, the University of Ottawa Brain and Mind Research Institute, the Children's Hospital of Eastern Ontario Research Institute, and we're also receiving funding from a private company named Mobio Interactive, and I'm receiving partial funding from Ontario Brain Institute. And the study that I will be presented later a bit during this presentation was supported by the OSU and a PSI grant. Briefly, an overview of today's presentation. We'll look at what is a concussion, and we'll strive to identify the recovery profile of pediatric concussion. Afterwards, we will describe some of the neurological changes after concussion and how we can measure these changes. And finally, we will look at how we can promote neurological and clinical recovery. And this is where we will be presenting some of our results from the PCARE and PCARE plus MRI study. Now, the Center for Disease Control and Prevention refers to concussion as a silent epidemic because there are numerous cases of concussion that go unreported each year. And this is principally due to the fact that symptoms are not visible. Only 1 in 2 Canadians have little or no knowledge about a concussion, and 1 in 4 do not know how concussions are treated. Unintentional injuries are a leading cause of death, hospitalization, and disability among Canadians. And of these, concussions are among the most common. Now, in 2013, approximately 35,000 pediatric concussions were reported in Ontario. And from, as we can see on the graph here, from 2003 to 2013, visit rates for 100,000 children increased over 4-fold. So we're making progress at reporting, but unfortunately, it is still an underreported. Concussions are still underreported. Now, the major cause of a concussion are fall. And in Canada, 54% of all pediatric concussion occur in sport participation. So not just full contact sport. Now, I just went through a bunch of statistics, but what is a concussion? A concussion is a subtype of mild traumatic brain injury, and the injury is induced by a direct or indirect blow to the head, to the face, to the neck, or anywhere else on the body with an impulsive force transmitted to the head. So you don't need to get directly hit on the head to suffer from a concussion. And the concussion is basically caused by these biomechanical forces, such as acceleration, deceleration, and rotational forces that are applied to the brain that will trigger acute and subacute biological and metabolic cascade of events leading to symptoms. Now, there are many signs and symptoms to a concussion, and these can appear up to 48 hours after having a concussion. We characterize these symptoms into 4 categories. So we have the physical symptoms: headache, nausea, dizziness, sensitivity to noise, sensitivity to light. We also have cognitive symptoms after having a concussion, or there can be cognitive symptoms. So for instance, feeling slowed down, difficulty concentrating, difficulty paying attention, difficulty taking decision, and difficulty remembering. We also have sleep disturbances, so sleeping more or less, difficulty falling asleep and staying asleep. And finally, we have a category that's not often discussed, but these are the emotional and behavioral symptoms, such as feeling irritable, nervousness, frustration, anger, and sadness. And these concussion symptoms can evolve over time, but we actually do not. And finally, just a note, and this is really a side note, I think it's important to highlight that we actually do not have a biomarker to diagnose concussion at the moment. So research are still ongoing to figure out how we can really diagnose concussions. And so that having been said, there is a lot of symptoms after having a concussion. But it's important to know that most children will actually recover over a 4-week period. And our work has shown that overall 52% of children have recovered by 4 weeks and 64% of children have recovered by 12 weeks. And when we review the proportion of recovery over time separated by age, we see that by 12 weeks, 71% of the children between 5 to 7 have recovered versus 70% of youth between 8 to 12, versus only 56% of adolescents in the age group 13 to 18 years of age that have recovered. And we can really clearly see with these 3 graphs that there's a greater proportion of males that have recovered at each time point for each age group. And when we look at the natural recovery trajectory over time, where recovery is defined as symptom improvement, represented by these curves. So the y-axis is symptom score and the x-axis is time. Symptom improvement occurs really within the first 2 weeks in the younger age group, within the first 4 weeks in the 8 to 12, and in male adolescents 13 to 18. And after 4 weeks, we really see symptoms start to plateau and changes in symptoms start to slow down. And females in the age group 13 to 18, symptom improvement occurs really within the first 8 weeks post-injury until it starts plateauing. And what is important to remember is that these within these graphs is that how steep the curve is within the first 2 weeks, first 2-3 weeks. And so early intervention seems to be really a key to try to prevent long symptoms before, you know, that curve or symptom change start to plateau. And so that really leads me to discuss that there is, in some kids, there's actually approximately 30% of the pediatric population that will have persistent post-concussive symptoms. And so persistent post-concussive symptom is defined as having 3 or more new persistent symptoms at 28 days post-injury, which can last for months to sometimes years. And these symptoms really impact the quality of life of children and parents. And in our previous work, that was which Roger Zemek was the senior lead author, we compared the quality of life of the participants with a concussion who had persistent symptoms, which is in yellow, versus no persistent symptoms, which is the line right here in blue, so the blue squares. And so it seems that children with persistent symptoms at 4, 8, and 12 weeks, sorry, oh, all right, someone's saying to get closer to the mic. Okay, so I'm going to talk louder. So it seems that those that do have persistent post-concussive symptoms, well, it's harder for them to take part into activities because they have low energy. They seem to miss school and activities more often. They have emotional impairment, so feeling sad and angry. They have poor social quality of life, so they have trouble getting along. For example, they can have trouble getting along with other kids. And finally, they have difficulty in school, difficulty paying attention, difficulty concentrating. So overall, the kids with persistent post-concussive symptoms really have lower quality of life. And so finding an intervention that really reduces symptoms, that tries to prevent persistent post-concussive symptoms and increases quality of life seems to be really important. So just in summary, we just saw that how a concussion can change our behavior and how we can, and if there's prolonged symptoms, this can develop into persistent post-concussive symptoms. But what happens to the brain after a concussion? And so what what does it mean, this acceleration, deceleration, and rotational forces that are applied to the brain, and what happens? And so I would like to show you a neat little video that was posted by the New York Times. And so we're going to see in this video, so it's player 81 that gets a concussion. And what they did is they applied sensors, so accelerometers within the mouth guard of the football player to be able to recreate the concussion and create simulation of what occurs in the brain after a concussion. And so after the impact, we will note that there will be stretches that will sorry, the dinging of my phone just kind of distracted me, but there will be wave-like stretching that will occur to the brain. And as we can see, and right after the impact, so the impact is completely done, we can still see the brain shifting up and down, so sideways, after having the concussion. And what we note is when they recreate the simulation, which we're going to see in a few seconds. So they split the two hemispheres in half, and the both hemispheres are actually separated by this membrane that is thicker, so it separates the two lobes, and this membrane is called the falx cerebri. And really this membrane, what happens is it kind of intensifies and concentrates the stretching in the brain. And as we can see in this simulation, where there is actually the most stretching to the brain tissue is in the corpus callosum. So right here beneath the falx cerebri membrane. And so concussion will lead to diffuse injury and will disrupt the normal functioning of the brain. The impact will trigger acute and subacute biological metabolic cascade events leading to symptoms. Now just let's review some of this damage. So first of all, as I just said, there will be damage to the cell and brain tissue. And this damage is really to the microstructural component, including the dendritic fibers that we can see right here on the image, and as well to the axon. So the axon really helps to transmit signals from neuron A to neuron B. And what we note is there is axonal stretching, and this axonal stretching will induce a cascade of biological mechanisms contributing to axonal swelling. And there will also be associated neurofilament compaction, microtubular disassembly, and there might be as well axonal disconnection and axotomy as well that can occur after concussion. And so the diffuse axonal injury has been demonstrated numerous times with diffusion tensor imaging, and its derivative measure called fractional anisotropy. And so what exactly this is, essentially fractional anisotropy is that we measure the degree of directionality of water in the tissue, so in the axon right here. And so, for example, increased fractional anisotropy indicate that there is microstructural damage to the white matter, so to the axons of the brain. And how this kind of works, if we just have water freely moving into a glass of water, well, it's actually quite low in anisotropy. But if we condense the water molecules, so if you think of water traveling into a tube or traveling into the axon, it's more condensed. So it forms an ellipsoid. But when the axon gets really thinned out or gets really compressed, well, that ellipsoid gets flattened out. And so what we measure in diffusion tensor imaging and with this metric is really the measurement of the vectors, right, of the ellipsoid. And so the region that is most often reported to be lesion, as I previously said, is the corpus callosum. And multiple, but not all studies show that persistence of these changes, so in fractional anisotropy, as clinical symptoms and other measurements have resolved. Now, after sustaining a concussion, there is a complex cascade of ionic, metabolic, and physiological events that will occur to the neuron itself. And so another important modification that's worth discussing is the influx of potassium, influx of sodium and calcium, and the efflux of potassium. And basically what this means is just this ion flux that's going to enter the neuron will create a depolarization, and it's thought that it's actually going to create a spreading depression-like state to the brain, where there will be a lot of glutamate release, and glutamate is an excitatory neurotransmitter that we have in our brain, and it's really thought to be, so this release is really thought to be associated with headache, as well as photophobia, so sensitivity to light and sensitivity to noise. And so following this depolarization, this is where we're going to see an energy crisis. So there will be, the brain will be in an energy crisis. And one reason for this is because the metabolic glucose required are really high compared to what is provided through blood flow, because there is a catalyst to the Krebs cycle. And so what exactly did I just say? Basically, there's so much calcium within the neurons that it's affecting the mitochondria. And the mitochondria, as we know, is the essential little organelle that takes care of producing ATP, that takes care of producing glucose. And so if this one is altered, so if mitochondria are altered, then it's harder to produce energy. And so there will be a metabolic dysfunction, and the brain will be in a state of cerebral vulnerability. And so it's thought that this metabolic dysfunction is really one of the causes as well to cognitive symptoms that we see after a concussion. And finally, lastly, another modification I'd like to discuss, which will lead us into our P-care, into our study, is altered cerebral blood flow. And altered cerebral blood flow is really well-recognized phenomenon in TBI, and it's likely play a role in secondary brain injury that evolves following the primary insult of a concussion. And so cerebral blood flow alteration during recovery can actually occur as a result of for different reasons, such as structural microvascular injury, changes in cortical excitability and network activation, but also altered physiological coupling of cerebral blood flow to the metabolic demand. So as I just previously said, we are in kind of a metabolic demand crisis. And essentially what happens is when I ask you a problem, let's say I ask you to do 2 + 2, when I ask you to do a cognitive problem, there's actually usually an increase in blood flow. And this increase in blood flow brings oxygen and glucose as well to be able to provide enough energy to resolve the 2 + 2 equation, right? And but what happens in concussion? It seems there's a coupling of this mechanism where blood flow is not necessarily providing enough glucose and oxygen. And so it's thought that the cerebral blood flow or lower cerebral blood flow might be due to this neurovascular coupling, uncoupling that is occurring. And so something neat is that we're starting to be able to image and to be able to measure cerebral blood flow. And there's this technique called arterial spin labeling, and it's there to quantify really perfusion. And basically what this technique does is it indirectly measures cerebral vascular control. And so it uses magnetically labeled arterial blood water as an endogenous contrast agent. So what exactly did I just say? So what happens in an MRI is that we have hydrogen. So what happens in MRI, you're in the MRI, and what occurs is we have water in our brain, right? And we kind of play with the spin of the hydrogen that's within the water of the blood. And so in a control image, we take a control image where the brain, we're not applying really any sequence to the brain. And we take an image of the hydrogen nuclei spinning with the magnetic field. So as soon as you're in a magnetic field, your hydrogen are actually spinning on the same, and they're rotating equally at the same speed. But then we take a second image, which is called the label image. And this is where we actually apply a pulse signal that will cause a magnetic inversion of the hydrogen nuclei in the blood. And so we obtain, as you can see in the label image, the blood now is no longer really, the hydrogens are now spinning on a reverse side. And so if we subtract the label to the control image, we get a measurement of blood flow through the brain. And this measurement gives us a measure of cerebral blood flow in millimeters per 100 gram per minute. And so research that has actually used this technique has shown that, generally speaking, right after concussion, the brain is in hypoperfusion, and for about 1 to 3 days, and afterwards, in adults, usually the perfusion or cerebral blood flow will actually start normalizing itself. But in children, it seems that it will go into hypoperfusion, and then it will go into hyperperfusion to afterwards normalize itself. And it seems that those that are symptomatic, even at 4 weeks, they're in a hyperperfusion mode compared to those that don't have symptoms. And those actually are asymptomatic are compared to just the control group, to a healthy controlled population, they're actually in hypoperfusion. And so it seems that we still have modification that is occurring to the cerebral blood flow even at 4 or 5 weeks. And when we follow through, so this paper that was done in 2021 followed these kids for over 10 weeks and noted that those that were symptomatic at 4 or 5 weeks, their trajectory, they had really poor recovery in terms of cerebral blood flow at 10 weeks. They were still, their cerebral blood flow still was not normalized compared to those that had really good recovery. We can see that their cerebral blood flow actually came down, so it wasn't a hyperperfusion, and normalized itself. So it seems that neuroimaging such as fMRI, ASL, BTI, and other measurements that I haven't discussed, so spectroscopy, seems to be really an adequate technique to assess and quantify recovery in concussion. So in summary, we have seen that concussion will impact quality of life, cognition, mood impacts, and will also impact the brain. And so the question is, how can we promote neurophysiological and clinical recovery? Can we measure these changes objectively with neuroimaging? And so the answer might be as simple as physical activity. Now, a still widely used practice is to advise of rest and only start back physical activity once completely symptom-free. And it seems that actually protracted physical rest may actually negatively impact those that have sustained a concussion and might impact actually their recovery. And this might result in more anxiety, depression, and more physiological deconditioning. So instead of prescribing rest, perhaps prescribing physical activity might be key, because there are numerous physiological, psychological, and functional benefits to physical activity. It improves your mood, your sleep, your cognition. In kids, it improves academic performance. But something else that it does, it actually improves or engages our cerebral vascular control mechanism. And so when you think about it, when you do physical activity, it actually triggers on our motor neurons, right? You're jogging, and this will require more glucose and more oxygen. So it will help to recondition the cerebral vascular coupling system that seems to be altered after having a concussion. And as well, physical activity does increase cerebral blood flow. And there's starting to be many studies, so preclinical studies that indicate an increase in these proteins that we call neurotrophic factors. And these neurotrophic factors are usually when we have an increase in, for instance, in brain-derived neurotrophic factor, this actually helps the brain repair itself. So it helps with neuroplasticity, creating new synapses. It helps generate new neurons, and it helps as well to repair the vasculature system. And finally, physical activity has been demonstrated to reduce inflammation. Now, and this is what actually we decided to study at CHEO. So in a study that was conducted in 2016, we found that resuming physical activity within 7 days post-injury was actually associated with a lower risk of having persistent post-concussive symptoms. So those that did resume physical activity within 7 days, they had 24.6% risk of developing PPCS compared to those that were only resting. Their risk was about 43.5%. And so it seems that active physical rehabilitation seems important. And so randomized clinical trials are needed to confirm these findings and to determine optimal timing for initiation of physical activity. And this is what we did here at CHEO. So the study is called Pediatric Concussion Assessment of Rest and Exertion. This was a multi-center randomized clinical trial. So it was conducted at SickKids, CHEO, and Children's Health Center in London, Ontario. And so a summary of our objectives that we're going to discuss today, because we have numerous objectives for this study, but we wanted to investigate whether early reintroduction of non-contact physical activity at 72 hours reduced symptom burden at 2 weeks after an acute concussion compared to usual care. And at that time, usual care was rest until symptom-free. And we wanted as well to see if it was feasible to scan a portion of these kids and to look into whether physical activity or early return to physical activity improved cerebral blood flow in patients at 4 weeks compared to our rest until resolution protocol. And so, as I previously mentioned, this was a randomized clinical trial. And so we had two groups that were investigated. The first, we can call the first group the experimental group. So the experimental group is the intervention, and the intervention is early gradual resumption of non-contact physical activity, which is initiated at 72 hours. And our control group was rest until resolution of symptoms. And afterwards, children could gradually return to physical activity. And we're going to see the intervention in a few moments. So our estimated sample size was 350 participants. Our inclusion criteria for the study were patients needed to be aged between 10 and 18, had incurred an acute head injury within 48 hours prior to the ED presentation, and diagnosed with a concussion according to the Zurich-Berlin consensus definition. We have multiple exclusion criteria, but just for the time, we can discuss this in question period. But just please note that participants were excluded if they had a GCS under or equal to 13, and they were excluded if they couldn't perform physical activity, or if they couldn't resume physical activity. Now, our intervention, as previously mentioned, we had two groups. So the first group, which is the intervention, the experimental group, they needed to rest for 72 hours, as we can see. And our no intervention group, they needed to rest until symptom-free. So this is a bit of the booklet that we had, a glimpse of the booklet that we had given participants with instructions for both intervention. And if we take an example of the intervention group, for instance, or the experimental group, after 72 hours, they, even though they had symptoms, they could start to do physical activity. And so the first stage is walking, and it's really walking lightly, so to a very, very easy pace. So we always gave them how much physical activity, so the intensity of physical activity that was required for each stage. Another example, just for instance, if symptoms were tolerable after walking for 15 continuous minutes, the next day they can move on to the next stage, which was light aerobic exercise. And basically what this was, for instance, light jogging. And so they could do light jogging to a step 3, step 4, according to the PCERT diagram below. And so it kind of went on like this for 5 stages. So stage 3, this where in stage 3, we could do a higher intensity physical activity. So if you could jog, but jog faster, so to a higher intensity. And then finally, stage 4 is high intensity exercise, but you can start returning to your drills, to your sports drills, and you always increase intensity. And so in the no intervention groups, and the rest until asymptomatic group, these stages were the same, except participants needed to be symptom-free to be able to move from one stage to the other. So that's the big difference between both groups. Now, once participants were randomized, they were followed up daily with the completion of symptoms and activity diary. And to measure their adherence to the protocol, participants' daily movement behavior was tracked with an accelerometer. So we had Actiles that were provided from Mark Tremblay's laboratory. And so these Actiles were positioned on the waist and on the right side of the waist, and participants needed to wear this device for 14 consecutive days, 24 hours a day. And the primary outcome measurement was a total self-reported health and behavior inventory score at 2 weeks post-injury for objective number 1. And so the HBI is, as I said, it's a self-reported assessment, is a 20-item symptom so it's a 20-item symptom list with 4 points rating scale of symptoms. Sorry about that. So we randomized over 456 participants. A total of 229 were part of the rest until symptom resolution group on this side of the screen, and 227 were part of the early physical activity group, which is on this side of the screen. So a total of 353 participants, so 173 for the control group versus 180 for the experimental group, completed all follow-ups at 2 weeks post-injury. And we note a slightly higher proportion that were lost to follow-up in the control group versus the experimental group. Overall, when we look at our descriptive statistics, the median age is around 13 for both groups, and the groups are composed of around 44% females. And so groups are quite balanced for many of the personal characteristics. However, we can see a slight imbalance in the previous concussion, which is right here, and in the fatigue variable. And group symptom score are equivalent in both groups. So their HBI score in the ED is equal for both groups. So both groups were quite equal starting the intervention. And so in terms of results for this first objective, we did not find any adverse events. So no adverse events occurred during this study for either groups. And our result was the first analysis that we did was, of course, an intention to treat analysis where we used linear multivariable model. And so in this model, we adjusted for prognostically important covariates such as sex, age, prior concussion, and symptom duration, migraine history, balance error scoring. And we as well covariated for some of the acute signs and symptoms. And so results of the intention to treat demonstrates that there is a minus 0.13 difference, mean difference. And basically what this means is that returning to physical activity at 72 hours reduces your symptoms of 1.3 points on the health and behavior inventory. So it's not a lot. And actually, as you can note, that this difference is not significant. Now, to investigate compliance with the treatment protocol, we did sensitivity analysis with the Actile data. And so what we did is we looked at all the data, and we looked at those that actually had adhered to the intervention. And we only took those that had adhered to both groups and both instructions. And so when we look at the Actile data, there's only a total of 259 participants, so about 58% of our population that had valid Actile data, meaning that they were worn for more than 10 hours a day for at least 4 days for the 2 weeks period. And of these participants, we note about 143 had completed primary outcome data at 2 weeks and had adhered to the intervention. So we reduced our sample quite considerably. So many participants did not really adhere. So according to the Actile, did not really adhere to the intervention. And so after applying the same modeling strategy, what we note is in our protocol analysis is when you resume physical activity at 72 hours and you're really adhering to the protocol, this reduces your symptoms of about 4.3 points on the health and behavior inventory. Now, this finding is slightly significant, as we can see. So it is significant, but you can note as well that our sample size is quite reduced as well. And so there is evidence that neurophysiological abnormalities will persist in time beyond the clinical recovery. So we find this finding often where there will still be, patients will be asymptomatic, but we're still going to see differences on neuroimaging studies. And so the window for cerebral vulnerability may be longer than the clinical signs, and this might have actually consequences on our management protocols and on whether children can actually return to sports at 72 hours. So we thought as a feasibility trial to scan participants, a subsample of our PCARE sample, to scan them. And so what we did is we took 29 patients from the experimental group to 29 patients from the control intervention. And we also recruited a no intervention group, which was an orthopedic comparison group. And we scanned them at 72 hours and at 4 weeks. So within 72 hours of their concussion or their injury, and we scanned them as well at 4 weeks post-injury. And so the reason why I recruited an orthopedic injury group is really to have a neuroimaging comparison group to really understand what is normal, let's say in terms of cerebral blood flow. And the orthopedic injuries are really thought to be the best comparison group in concussion, as they have as well suffered the trauma, they have been through the ED, and they do have the anxiety due to the injury. And so, as I previously said, participants were required to have 2 MRIs, one at 72 hours and one at 4 weeks. And the MRIs that they received was at the Brain Imaging Center at the Royal Ottawa Mental Health Center. And so we gave them a bunch of different sequences, 2 that you will note. So we had an ASL sequence, arterial spin labeling, to measure cerebral blood flow. And we also measured diffuse and tensor imaging. I haven't spoken about resting state fMRI, but this is an equally interesting sequence where you can find interesting finding in concussion as well. And so after enrolling, after noticing that many participants had clinically significant findings. So after removing these participants from our sample, after removing participants that had moved a lot in the scanner, we end up with 32 participants part of the control group, so the rest until a symptom-free group, versus 38 in our early physical activity group. And with our OI group, we had recruited 46 participants, and we, after removing promotion and removing clinically significant findings, we have 29 participants that are left in the group. So sample size are low. And when we look at personal characteristics, groups actually seem to be still quite balanced. However, there seems to be a higher rate of females in the experimental group and a higher rate of ADHD in the experimental group as well, compared to the control group and the OIs. Now, when we look at differences in terms of global perfusion, so in terms of global cerebral blood flow at 4 weeks, while co-varying for global perfusion or cerebral blood flow at time 1, we know that there's actually no difference in global perfusion, that is in gray matter, white matter, and whole brain in time 2. Which can be expected for global perfusion. So what we decided to do is just to look at perfusion regionally in the brain. And this is where we actually know differences between the control group. So CG means control group. This is also labeled as group A, and EG is the experimental group, also labeled as group B. And so when we compare just control group versus experimental group, we know that there's actually higher perfusion in the experimental group in the right supramarginal gyrus, right as well, which extends into the superior-temporal gyrus. We also note right putamen increased perfusion, and as well the right posterior cingulate cortex. And the right posterior cingulate cortex is actually quite interesting because in literature, this is a region that is often referred to be altered after having a concussion. And it seems that it can predict, so the alteration that we see in the posterior cingulate cortex can predict attentional impairments. And so basically, and so sorry, I just missed something here. When we compare these, I mean, we get higher perfusion, but what exactly does that mean, right? It's not telling us much information apart that one group has higher perfusion. And so this is where I included the orthopedic injury group. And when we compare these regions that have higher perfusion in the experimental group and compare it to the orthopedic injury group, so again, group A right here on the left side is the control experimental group, group B is the experimental group, and the OI group is right here on the right side. And so we start noticing that we can really clearly see here that, you know, one group has really higher perfusion, the other one has hypoperfusion. And when we compare it to the orthopedic injury, well, these guys that are in group A have lower perfusion, and these guys that are in group B have higher perfusion. So just these results are actually quite interesting. But when we compare it to orthopedic injuries, we don't really see statistically significant differences in terms of their perfusion. And so I wanted to compare these results with their health and behavior inventory. And as we can see, if we just look at the health and behavior inventory at 4 weeks, we note that the control group actually, so group A has less symptoms than group B, but this is not statistically significant when we compare it to the orthopedic injury. Pretty much everyone has, you know, the same levels of symptoms. And what I did is I correlated, or I did a regression with the HBI total score and the HBI subscore, so cognitive and somatic score, and I regressed them with the perfusion regional group differences that we had found. And we find that those that are part of group A, so those that are part of the control group, well, there's a negative correlation with the total HBI and the cognitive subscore, meaning that the lower you have perfusion, it seems that the higher you have total symptom score and total cognitive score. So you have more cognitive symptoms, which was I found quite interesting given the literature on this particular structure. And just side note, and this is just really for fun, which I added this morning. We did compare just briefly group A versus group B in terms of DTI and looked at their fractional anisotropy. And we find that in group A, they actually have higher fractional anisotropy in the right cingulum, which really corresponds well with the results that we are seeing right here in the posterior cingulum cortex. And finally, I'm almost done. I wanted to look at what the Actile data was telling me, just to see if I could make more sense of the data that was looking. And this is the Actile. So this is the variable moderate to vigorous physical activity. And so once again, group B is our control group, group A is our control group, sorry, and group B is our experimental group. And it seems that group A did more physical activity over time compared to group B. But when we compare them directly, total moderate to vigorous physical activity is comparable. So there's no significant difference. And there's no significant difference either between both groups when we separate it in time. So if we just look at, you know, day 1 to day 3, there's no real significant difference. But this is kind of informing me that, you know, some of these patients that are part of group A of the control group might not have adhered to the intervention. And so when we remove and we just look at those that actually adhere to the intervention and look at their perfusion, we don't really know. We note some regional differences, but these regional differences are not statistically significant. So we don't note really statistically significant differences between the experimental group and the control group. And so my conclusion remarks is that behaviorally, early resumption of non-contact physical activity after a concussion is safe and may reduce symptoms. Now, lesson learned, measuring compliance is actually extremely important behavioral intervention. And it's really important as well for note to myself to actually have a higher sample size in neuroimaging, because those that don't adhere will actually reduce your sample size. And it seems that neuroimaging such as fMRI, ASL, DTI, spectroscopy are feasible in the pediatric concussive population. And I think personally that we should use these imaging techniques to really help us understand the brain, understand the recovery trajectory in concussion. It can add a lot of information. Thank you.
Great. Thank you very much, Andrée-Anne. That was a very comprehensive overview. We'll open the floor for comments or questions. And to see if you can raise your blue hand if you have a question or a comment. Or if not, if you don't have access to that, perhaps you can just put your hand up or just speak up. Roger.
So tremendous job, Andrée-Anne. A very amazing summary of the amazing advantages of neuroimaging and the cutting edge work that you're doing. One question I had was, when we've looked at comprehensive meta-analyses and systematic reviews, as clinicians, we still don't really have effective treatments for concussions based on medications. One of the few studies that may show some potential benefit to reduce headache in the short term was a study done by Angela Lubna-Brown. She's out at Stanford. She's a pediatric emergency physician there. And she did a study several years back looking at a 10 milliliters per kilogram infusion, and it was a randomized control trial of hypertonic or 3% saline versus normal saline. And often we give 3% saline in the setting of brain injury from more moderate to severe as a way to increase cerebral perfusion. And I was curious if you thought that would there be changes in imaging if you had looked at that sort of intervention on either your ASL or the DTI imaging for the concussion patients? And do you think that the combination of overhydration, perhaps to increase cerebral blood flow, and exercise may be a combination therapy that could be effective?
Yeah, I know a researcher that I think has started doing that with his population in the States. And I think, so for your first question, whether we would be able to see it in ASL, so in perfusion, I think we would be, if there is an increase in cerebral blood flow after saline, we would be able to see it, and we would be able to see it really fast. And that's what's really important with this sequence, is that we can actually track these participants really early on, but we wouldn't be able to see it with DTI. And DTI, what's happening in DTI is that it takes a long time for there to be modification done to the axon. So if there would be a sequence that we could really see the modification of saline, would be with ASL. Now, your second question was whether saline combined with physical activity, would that be helpful? So unfortunately, I'm not super familiar with giving saline to a concussive population. But if this is safe, then I don't see why we shouldn't be trying it. But there's other ways I think that we could try other perhaps medication to try to really reduce, that glutamate release, and perhaps we would then see a more of an increase in signals in the ASL sequences.
Thank you. Other questions or comments? Maybe I could just ask you a little bit about the accelerometry data, because getting accurate accelerometry data in the pediatric population can be very, very challenging, and especially if you're going to go for 14 days consecutively and expect. So I just wonder, did you have any other surrogate marker of physical activity that was included that you might be able to use to extrapolate to the larger group, as opposed to just the relatively small number that you ended up with
Yes.
for a particular analysis?
Yeah, and you raised an important issue right there. Dr. Duffy. So we had logbooks that we used to monitor how much physical activity they did. And we also added, and this is more for the neuroimaging component, but I added an assessment, so a self-assessment of physical activity that they needed to do at 72 hours and at 4 weeks. So we could use that assessment. But once again, this is a self-assessment, and self-assessment in physical activity, it's really, really hard to rate how much activity you did in the last 7 days. And we see, just looking at how these patients logged it, we see that it's a bit problematic. You know, some patients say they did 300 minutes of physical activity in a day, but that's, you know, that's not realistic, right? So I'm not sure how much more valid this assessment would add. But you raised an important issue, and I think, you know, restarting this trial, I would have Actile data, but I would probably have another measurement that would be captured, perhaps, you know, another validated measurement, such as, you know, them wearing their cell phones, to just see if we can have extra data on physical activity.
Thank you. Martin?
Oh, great job, Andrée-Anne. My question is sort of along the same lines. You know, we always, once we've done a study, we have lessons learned that we can bring into future research, and there's nothing like doing a real world trial to learn how hard it is to do a randomized control trial and to get accurate outcomes. So you mentioned about compliance and compliance being an issue, and you know, you're dealing this population is an adolescent population. So what have you learned about compliance and trying to get the participants to be more compliant with the study protocols? What did you try, and what did you learn, and what would you do differently next time?
So what I've learned is, I think being in contact on a weekly basis with them, so once a week, I think that would be sufficient enough to increase adherence to the protocol, making sure that, you know, they understand the protocol, that they are doing it right. And I think that's really important, behavioral interventions. And this is something that we'll be bringing forward into our next clinical trial, that we'll be looking at mindfulness-based intervention in kids. So we're going to have a coach that's going to help them on a weekly basis. So I think that's a lesson learned. I apologize, I can't remember your two other questions.
I think it was all rolled into one. It's all about compliance and really how to, you know, getting teens to wear anything would be tough, and to get them to wear an activity monitor for 2 weeks and then comply to either exercise or not exercise can be tough. And I guess whoever is on this grand rounds will be doing different kinds of studies using the population, and so we can all share ideas about how to help.
And I think what I just said really is right now for me what I think will be the best way, and just reading the literature on coaching. I think just having a coach there, and here, you know, we can use quote unquote an RA just on a weekly basis, texting them, just making sure that they're adhering to the intervention and that they are understanding the intervention. I think that might be the best way around it.
Fabulous. Thanks.
There's a question from Dr. Chada around early exercise or not. I think Roger has answered it in the chat, but maybe you can pose your question again and we can get the experts here to respond.
Yeah, sorry, I think I missed it. So what is the conclusion?
So
I missed this one.
So the conclusion is that returning to physical activity at 72 hours is safe. It does not increase symptoms. It seems to actually be decreasing symptoms, and it does not. Returning to physical activity within 72 hours is safe, and we should be applying this into our management protocols.
Thank you.
It's just important, Joe, to add that it's important that it's low risk physical activity. So here we're not saying that kids can return with their skates on a skating rink to play a hockey game. It's just gradual return to physical activity is safe and should be applied through our management protocols.
Okay, thank you. Great.
Jason.
Karen, great presentation. Andrée-Anne. I hope you can hear me okay.
Yeah, now we can hear you, yeah.
Oh, great presentation, Andrée-Anne. I wonder if you can, and this is sort of more of a philosophical or predictive question, as we're coming out of the pandemic and changes in activity patterns are likely to ensue with encouraging kids and the opportunity for them to be more active, do you think we're likely to see an increase in concussions, or do you think that the current attitudes around people being more protective, aware with the pandemic may actually result in, to the questions that Martin's asked around compliance, people being more compliant, more cautious, and actually us not seeing an increase?
Well, I think, as soon as you put kids with other kids, I think concussions will occur. So I think we will be getting back to our usual rates of concussion as soon as the economy opens back up and sports open back up. But Roger might have a different opinion on this. But personally, I think we will be, right now we actually have no concussions at all really in the ED, but I'm pretty sure as soon as sports open up and kids are actually allowed to go back outside, I don't think there will be a protective effect. I think that there will be concussion, yes.
Since Andrée-Anne brought it, I would agree with Andrée-Anne's. In our large prospective studies to look at the overall epidemiology of concussion, about 75% of pediatric concussions are due to sports, as well as there's a large number of falls in the recreational setting as well. So recess, downtime at schools. And since kids have not been allowed to do those activities, I think that, as Andrée-Anne says, once those things resume, there will be a spike. We still are in the emergency department still seeing the occasional concussion, but it's just at lower rates. There are still motor vehicle collisions which result in concussions, assaults, things like that, which still can cause concussion outside of organized sports. But I agree that there'll likely be some pent-up demand to do sports. So I think kids are excited to get back to these activities, which will lead to an increase.
And I think that the word excitement is important, right? They will be excited, and so they might actually not even think about safety as what they used to, and it might actually create that spike in concussion.
So we'll draw it to a close. Thank you very much, Andrée-Anne, for your excellent presentation. This is really a very interesting work, and I wish you well with your future work. And not that we want to encourage kids to have concussions, but I guess your work will be dependent on it. So I wish you well as you proceed with that. Thank you.
Thank you. Thank you, everyone.